Yes, you can.
Another indication for the urodynamics, for the urological indication, with the patient having mixed urinary incontinence, females with mixed both stress and urgency, and we're going to do any kind of invasive management. Actually, that's quite a problem when the patient gives you symptoms and she's not understanding well what you're asking. So we all know that when you have a patient with mixed urinary incontinence, we usually ask the patient, what is the most prevalent thing you are complaining of? Is it the stress type or the urgency type? Because we have expectations as physicians, and the patients also have their expectations. So actually, we should put the patient's expectations in our consideration. Don't treat what you can treat. We treat what the patient is disappointed of. And lastly, when the patient has undergone surgery for stress incontinence, whatever, and it has failed, so we need to do urodynamics to understand the cause of this failure. Also, young men with severe obstructive symptoms. I know this is not the domain, but of course, young female, if they have strong, severe obstructive symptoms, you have to do urodynamics. Why? Because they don't have any obstructive lesion, don't have any urethral stricture, so you need to know why. Definitely patients with post-prostatectomy incontinence, those who have undergone prostatectomy, and you want to understand the cause, we need to do urodynamics after we exclude any organic cause, like, for example, urethral stricture post-operative, for example. Sometimes we may have problems with incontinence in a new bladder, what we call the reconstructed lower tract after augmentation, cystoplasty or whatever. We can do some urodynamics to understand what's the problem. You can do also stress urodynamics in female patients with stress urinary incontinence if you are going to do surgery. Actually, we have also very nice paper, which it's called the value trial. And the value trial have kind of the comparison between two groups of patients, female patients who have undergone urodynamics before and then did the surgery for the tape, and another group which did not do urodynamics and they went to do the tape directly. And actually there was no difference. So if the patient's symptoms are so clear, you can go for the tape directly without doing urodynamics. It's not a must if you can understand well from the patient. Lastly, one of the indication is what we call the refractory nocturnal enuresis. Those patients, the children, for example, they have what we call, they're not responding to any kind of medical treatment and they have nocturnal enuresis. We can do urodynamics to understand the problem, what's causing them. Also, orthopedics and neurosurgeon, also they may ask for urodynamics. One, if the patient has kind of spinal cord injury. Usually these patients, they come after the road traffic accident, and the family and the patient himself are not also in concern with the urinary system. They are concerned mainly with the polytrauma patient, the back trauma, and the paraplegia, for example. But also they have to put in consideration that the urinary system is affected, and also the defecatory system. These patients, they present with constipation, alternating with diarrhea. So we have to know that because of this nerve problem which have occurred during the injury. Definitely spinal cord tumors, spina bifida. Patient with a prolapsed intervertebral disc, those who are having lumbar disc prolapse, this is very, very important, because if these patients, they develop this, we have to work earlier, because maybe these symptoms will be permanent if we do not treat before reaching this condition. What about gynecological indications? Those who have working in gynecology, yes, as I said, mixed urinary symptoms, failed surgery, and even before prolapse surgery, as we said before. These are the urodynamics we can do for our patients. It may start with uroflumetry. Uroflow, it's very simple. When it's not invasive, you can do feeling cystometry. I will explain this pressure flow study. We don't do urethral pressure flow now. Urethral pressure profile, it has been done in the past, more not now in the States, now in Europe, it's not done anymore. Even in Egypt, we don't do it anymore. I would just ask also my colleagues from Morocco, from Tunisia, and from Algeria, if they really do still do UPPs. We can do also pressure flow study with EMG to understand if there's kind of a detrusor sphincter dyssynergia, and definitely the video urodynamics, which is to really done to see the exact site of obstruction with the measuring of the pressures. Uroflumetry, as we say, it's non-invasive. Its role in the females is not that so much, because we know in uroflumetry we measure only the flow of the urine. So actually we don't have measurement of the actual pressure of the detrusor muscle or the muscle of the bladder itself. So it gives us a kind of crude assessment of the voiding phase. It's not that quite, we can say, accurate. We usually do it as a recommended screening test for patients with benign prostatic hyperplasia and to follow up of the urethral strictures. And it's quite common that the patient comes to your clinic to do this study. We can tell the patient to retain urine for at least 2 to 3 hours, and then she voids in this bathroom, which is sitting over this transducer, and the volume being urinated is the weight of this is converted to volume and recorded on a chart in milliliters per second. We have to put this in consideration. If the patient comes to you with a urinary voided volume in uroflumetry less than 150 cc, you do not recall on this amount. You have to repeat, because of course, when the flow is less than 150 cc, the flow will be low. We can measure all these, but really when you want to look for the most important things, we look for the voided volume, we look for the maximum flow rate, the Q max, and this should be coined with the post-void residual. You have to measure the amount of urine remaining inside the bladder after you do the uroflumetry. In this curve, you can see this is the normal uroflumetry, and you can look on this side, this is what we say, the Q max, it's 24, so this is normal. The normal, it's like a bell-shaped, looks like a bell-shaped curve, and the amount is about 167. So this is the representative sample. This is a normal uroflumetry. And again, here, this is how to, if you could do it, look into a graph. If you look down, you can see that this patient is voiding with a Q max of 16. However, the voiding time is prolonged. And this is what we say, this is a restrictive pattern of uroflumetry. It's very consistent with patients who have urethral strictures. This is another one, restrictive pattern, as you can see here, very low flow. This is one, is the maximum flow rate is 4 milliliters per second. The voided volume is 234. So actually, this is, we cannot tell obstructed. In urology, if you want to say someone is obstructed, that's to say that the detrusor pressure should be high and the flow should be low. But it does not mean that the flow is low only. If you want to know if the patient is obstructed, you should do complete pressure flow study to measure the voiding, the p-detrusor pressure. So in the male, the Q max is more than 15 to 20 ml per second. This is normal. And if it's less than 10 ml, we can say that this patient has something abnormal. What about the females? This is very, very important to know that the females, they usually void by relaxation of the urethral sphincter, and they can squeeze or they can push a little to void. This is very normal of a female. Why? Because the female urethra is only 4 centimeters and there is no angulation of the urethra. It's straight. And there is no prostate in the female. All these are causing kind of resistance, which is not present in the female. So if she only relaxes her urethra sphincter, she will void easily. So the Qmax will be higher. The bell-shaped will be shorter, and the flow time is even shorter at all. But in males, we have what we call nomogram. What's a nomogram? That's to say that for every period of age, for example, from 30 to 40 years, they have Qmax of a certain value. From 40 to 50, they have a certain value. But in females, we don't have nomograms. Again, we should remember that the normal flow does not exclude obstruction. It may give you one of two things. If you have a low flow rate, then it is one of two things. Either the patient is obstructed, or maybe the patient has poor detrusor contractility. Then we come for the invasive. Why we say invasive? Because we put a catheter to the patient. So if you fix a catheter, then this is invasive. We have the two main types. We have the conventional, which we usually do in our clinics. So the patient comes, do the study, and then leave. And the ambulatory, we actually resort to it in very, very few cases where the patient can have a catheter fixed with a device being connected to the patient, and he can leave to his home and then comes again to see if there are any kind of activities which are happening, which also did not occur during the conventional type. The main idea of our thing is to measure what we call the P detrusor pressure. We want to know the exact pressure of the detrusor muscle. And we have to know that we don't have any kind to measure this directly. So what we really do, we measure other pressures and then we do subtraction. We measure the P vesicle, the pressure of the bladder as a whole, which is equal to the detrusor pressure, the pressure of the muscle, plus the abdominal pressure. And then if you want to know the detrusor pressure, then we measure the P abdominal by itself, which we can measure through a catheter being put into the anus or even into vagina. And so if you subtract the P abdominal from the P vesicle, you will have the P detrusor pressure, which you are looking for. Usually the filling rates, we have many things to look for, but to make it easier, it's only 20 ml per minute in patients with neurogenic patients. This should be low because in these patients, you may have hypocompliant bladder. So they have, if you raise the filling rate, this will provoke some kind of overactivities, for example. And 50 ml per minute in the patients who does not have any kind of neurogenic bladder. We have 3 measurements, as I said. I will show you here on this graph better. But let's talk first about the catheter. We have one catheter which is put into the urethra, and this is a transurethral double lumen. Why it's double lumen? One lumen is for the measurement and one lumen is for the infusion rate. These catheters should be as small as possible. Why should they be as small as possible? So as not to hamper or not to cause obstruction of the flow when the patient is asked to void. And they should not be that large, it should not be that small, because if they are very small, they may dampen the pressure transmission. They may not lead to pressure transmission and limit the desired flow rate. So the best number to use is the 6 French double lumen urethral catheter. When we say what's filling cystometry, that's to say we measure only the detrusor pressure, the abdominal pressure, the vesical pressure, only during the phase of the filling phase, while the patient is only the bladder is filled without any voiding. We usually use fluid cystometry. In the past, we were doing some gas, but of course, when you use gas cystometry, you will not be able to identify any kind of leakage when you do the study. So the fluid we usually do saline, and if you want to do video urodynamics, you can put some kind of contrast material to see inside. Very important thing, especially in cold countries, when you do urodynamics, you should warm your infused fluid, because we know that the temperature, if the fluid is cold, this may induce overactive bladder or detrusor overactivity. So they should be at least not so hot and even not cold. They should be at near body temperature. And as I said, if you look here at this equation, the P detrusor pressure here, it is the P vesical minus P abdominal. So it's kind of equation which the computer itself makes every time. It usually only measures the P vesical through the urethral catheter and measures the P abdominal through the rectal catheter, and it gets the P detrusor automatically. So if you put this catheter, and you can see during the study, if you have a kind of change in the P vesicle and in the P abdominal, which are equal, and there was no change in the P detrusor pressure. So this, we can say that this patient has done something which increased the intra-abdominal pressure. For example, she was coughing, she was moving, she was laughing, she was talking. Anything which would raise the intra-abdominal pressure would lead to increase in P vesicle and P abdominal. But if you see the pressure changing on the P vesicle and the P detrusor and not on the P abdominal, then we know that this is a kind of detrusor contraction. Whether the patient had this spontaneous contraction, I mean, it is idiopathic detrusor overactivity, or if the patient is voluntarily contracting her detrusor, for example, to void. When you do the filling cystometry, you have to comment on 4 main things. Number 1 is the capacity of the bladder. How much is the bladder taking fluid inside? Number two is the sensation. And usually we have three kinds of sensation. We have the first sensation of bladder filling when the patient gives you that she is aware that the bladder is being filled. And this is equivalent to about 50% of her capacity. We have the first desire to void when the patient feels she can void now, but this could be delayed if necessary. She is not at too much stress to go to the bathroom. This is about 75%. And the strong desire when there is persistent desire to void, but still the patient is not fear that she will leak. And this is about 90%. And this is when we tell the patient, okay, you can void if you want to do the pressure flow study. The point which comes after is the compliance. It's very, very important characteristic of the bladder. That's to say, when you increase the volume inside the bladder, the pressure usually will rise in the bladder. But what's compliance? That's to say that the pressure rises inside the bladder slowly to accommodate more volume. And the normal bladder compliance should be more than 30 to 40 ml per centimeter water. This is very important because this is what keeps us not going into the bathroom every time. So we can still keep our urine for 3, 4, or 5 hours. We also comment on the detrusor overactivities, if they are there or not. And if they are there, what's their amplitude? And if they are there, whether there is kind of leakage or not, and the amount of leakage. And when did they occur? During the study, this is called phasic, or at the end of the study and was associated with leakage of the whole infused volume, this is called terminal. We also have to tell that if the detrusor activities are spontaneous or provocative. What's spontaneous? That's they occur from themselves without any kind of provocation. But sometimes the patient comes to you and says, I have detrusor overactivities. And you do the study and she's free. You don't see any kind of detrusor overactivities, no hyperactivities. So you want to see them, you can tell the patient to do some kind of maneuvers. She may cough. You may open some kind of tap water beside because this can cause irritation of the bladder, or simply you increase the filling rate. So in the storage phase, as I said, we comment on these 4 main things: the compliance, the capacity, the sensation, and the presence of the detrusor over activities. I will show you here some of these. This is a kind of urodynamic study. If you look here, this is the P detrusor. It's the top one, followed by the P vesicle in the middle, and then the P abdominal. If you look at from the beginning of the study, from this time, from here at 0.20, you can see 2 spikes, both occurring on the P vesicle and P abdominal with no change on the P detrusor. So we know this is a kind of increased intra-abdominal pressure. So the patient here, this is to test before we do the study. Then if you look afterwards, you can see some waves which appear on the P detrusor and P vesicle, and they are not there on the P abdominal. So these are detrusor overactivities. So this is kind of test just to see the difference between simply increase in P abdominal and increase in P vesicle and increase in the P detrusor pressure. What is the leak point pressure? We usually rely on this, the abdominal leak point pressure, in patients who have stress urinary incontinence. So what we really do, we tell the patient when we reach the half bladder volume, about 200, 250, and we tell the patient to cough many times, and we see if there is leak or not. And we can tell if there is leak, so this will be the abdominal leak point pressure. Usually during the cough, you will not be able to estimate the exact point of leakage because it's a sprout, it's a kind of burst of, it rises rapidly. If you want to know exactly, we do the Valsalva leak point. What's Valsalva? You tell the patient to hold her breath inside, and then she keep on squeezing or bearing down. And she bears down in a kind of increasing gradually till we can see the leakage, and then we will be able to identify the exact abdominal leak point pressure or Valsalva leak point pressure. Because accordingly, we can tell if the Valsalva leak point pressure is less than 60 centimeter water, this is a problem in the sphincter. And if it's more than 90 centimeter water, this is what we call urethral hypermobility, or what we call change in the position of the urethra, which has come down into the pelvis, and there will be this type of mild to moderate stress urinary incontinence. The detrusor leak point pressure is another point of leakage, but it occurs in patients with neurogenic bladders. And actually, when we look for it, we look only at the P detrusor pressure during the study, and we will see that it is increasing with associated increase in the P vesicle, and then leakage occur. And you don't see any change in the P abdominal in these neurogenic patients. So this is the lowest detrusor pressure at which urine leak will occur. And the importance comes from Maguire, which have said that the P detrusor pressure 40 centimeter or more, this will be harmful for the upper tract. So if you have this detrusor leak point pressure more than 40, then we should put into consideration that upper tract may undergo some hazardous complication and may be dilated. So to summarize, the normal bladder capacity is from 300 to 500 ml. The compliance, the curve should not be steep. It should be rising gradually. So it will have a constant low pressure, the bladder, and it does not reach more than 6 to 10 centimeter water. And there should be no kind of detrusor over activities. So this is for the filling cystometry. The pressure flow study, it is the same, but actually what we do in the pressure flow study is we measure also the voiding phase. We look for what we call the P detrusor at Qmax, the detrusor pressure at the point of maximum flow rate. The normal male has generally voids the P at a pressure from 40 to 60 centimeter water. Of course, females, they void at a much lower pressure. When we see P detrusor at Qmax more than 100, this is definitely a bladder outlet obstruction. What's an obstruction? It is a high detrusor pressure and a low flow. I will finish my presentation with just giving you some slides on the urodynamics. If you look here on this one, this is the P abdominal high up, then the P vesicle, then the P detrusor, and low, it is the flow. Look at the beginning. So the patient starts to cough. So there is a change in the P vesicle, P abdominal, with no change on the P detrusor. What happened after the cough here? There become a change, as you can see this wave, which is occurring in the P vesicle and P detrusor, but not here. So this is detrusor overactivity, which has occurred after a cough. So this is what we call cough-induced detrusor overactivity. This is very important because the patient will come here and say, I have stress urinary incontinence, but actually she does not have stress incontinence. She has overactive bladder. As you can see here, also she coughed again. You have this overactivity, again here, cough-induced, again cough-induced. What are these changes here? So this is leakage with this overactivities. So this is a cough-induced detrusor overactivity. It will present to us by stress urinary incontinence. Look at this one. This is a P vesicle, P abdominal, P detrusor, and the P, this is the Qmax. The P abdominal is high up here. So if you look on this curve, we don't see any kind of change here between the P vesicle and P detrusor. There is no spike here. Why? Because the operator, he forgot to do what we call calibration. What's calibration? Has to do to ask the patient to cough in the beginning to know if this is actually, the pressure is moving high up before doing the study, and to make sure that the catheters are working well. So if you go here, you will see that this patient here, when he was asked to void, look at the P vesicle and P detrusor, it rose up to 90, the P detrusor pressure, and the flow was Qmax was 9. So these are this is a very high P detrusor pressure and a low flow. This is definitely an obstructed patient. So what's this hasn't applied to our patients? If you have a patient with benign prostatic hyperplasia and the patient comes to you and he has diabetes, for example, and you said, okay, you have to do TURP, prostate resection, but you're afraid that maybe the bladder is not contracting well. You do the study. If you find that the pressure of the bladder is high, like this, then you tell the patient you will get benefit from the surgery. But if you have low P detrusor pressure, then you will tell the patient maybe you will not get benefit from the transurethral resection of the prostate. So for this patient, we did him also video urodynamics. As you can see here, this is his urethrogram, and you can see here he has multiple urethral strictures. So this is bladder outlet obstruction with a urethral stricture. This is another example, as you can see here. We had this P vesicle also in P detrusor, and the P abdominal is high up. If you look on the storage phase, you have multiple small waves, low detrusor pressures. But when it comes to the end, we also have the P detrusor is about 81 and the Qmax is about 2 or 13. So again, this patient is obstructed and has in the filling phase low amplitude detrusor over activities. So this is bladder outlet obstruction and detrusor over activities. So I just wanted to show you some kind of slides just to make it kind of applied. This is what we call the last one. I will show you the bladder compliance, the difference between the bladder compliance, hypocompliant, and the involuntary detrusor over activities. Just look at this is the P abdominal in the middle, P vesical and P detrusor there. So the P detrusor here starts its flow very, very low. Then it starts to increase gradually, as you can see here. This is equivalent to this one, and the P abdominal is just staying flat here, but it's increasing here. This is not a detrusor over activities, because if you stop the filling, it will stop. It will not continue to rise. This is how to differentiate between both. To stop the filling rate, if you have a low bladder compliance, it will not rise. It will stop. If it's overactivity, it will continue to rise. Here, the filling rate was done again, and as you can see, there was much high increase in the P detrusor pressure and the P vesicle. So this is superimposed detrusor over activities on top of this hypocompliant bladder. So this is a picture of what we call neurogenic bladder, very characteristic neurogenic bladder patient. And this high pressure, if you look at this, is maybe reaching about 70 or 80 centimeter water. This is very hazardous for the upper tract. It may affect the patient and cause deterioration of his kidneys as well. So by this, I finished my lecture for this. Thanks very much for you, and I'm ready to take any kind of questions from the audience.
Thank you, Wally. Je crois, avant qu'on passe dans les questions de la salle, on va essayer de voir Urodynamics qui est à Los Angeles avec nous, parce que comme il est de garde, si jamais il part, il sort de bloc. Urodynamics. Urodynamics.
Hello, I'm here.
Yes. Before, thanks, Wally, for this good and interesting communication about lecture Urodynamics of the bladder. Do you have any question about this subject? Or can you tell you about your experience and your aerodynamic experience?
That was a very good lecture. Thank you for that. I will say that in the United States, we tend to use a lot of video urodynamics for our evaluation. Maybe we're pretty biased because of how we use it. I wanted to ask, in your setting, how do you diagnose primary bladder neck obstruction, and what's your experience in that regard with urodynamics?
Yeah. You mean in females or in males?
In females.
In females. So actually, that's a kind of very tough one, because we know the primary bladder neck obstruction in females have been many etiologies, but actually the most important thing which will be the video urodynamics, because it will give us the site at which the pressure will increase and associated with this with the site or the bladder neck. Mm-hmm. So that's how you can tell only with the video urodynamics. Because if you do cystoscopy, you won't see anything. You will just see the kind of sequelae if you have some kind of trabeculations inside the bladder. Mm-hmm. But I totally agree that the video urodynamics maybe here is the only thing to go with it, because we know most of the patients, they may even void with relaxation of the bladder neck. So, or the relaxation of the sphincter. So when you do the normal urodynamics or pressure flow study, you may see that the pressure of the bladder is not rising. So you will tell that this patient has kind of detrusor acontractility or hypocontractility. And you will go into this dilemma and actually know the patient is only straining because she's adapted to do this. But if you do the urodynamics, the video urodynamics, you'll hear that the pressure here is maybe could be raised, but you could see the site of obstruction, and this will be the primary bladder obstruction. So I don't know, is this the same as you do in the States, or you have other comment about this one?
Yeah, I mean, I said that we primarily diagnose this off of video urodynamics, so we're able to localize the level of obstruction of the bladder neck, and we see that it doesn't open during the voiding phase, and there's still a sustained detrusor pressure.
Une question. Je lui donne une autre question parce qu'elle risque de partir, mais prends le micro quand même. Another question for you together. In your practice, you can treat urinary incontinence without perform aerodynamics?
I mean, so in our practice, I would say that, you know, urodynamics, like you said, Dr. Mustafa, is an objective measure. And I think that for a lot of women, especially, you know, your history is very important and is very key. So based on the history, you can really kind of elucidate what type of incontinence a woman has, whether it's stress incontinence or urgency incontinence. If there's any kind of question, or the woman is not reliable as a historian, or she has bother that's equivocal, that might be an indication for investigating further with urodynamics. Also, if you feel like urodynamics might guide your choice of treatment, then that might be another indication for urodynamics.
I guess it's the same also, but I just want to ask you one question. If you have a patient with a stress urinary incontinence and it's quite obvious and it's vivid and clear that the patient has a stress urinary incontinence and she will go TOT, TVT, whatsoever, do you do always urodynamics or not?
I mean, based on the guidelines, the AUA guidelines, in an indexed patient, so a patient that's uncomplicated, that's had no prior surgery, or has no kind of abnormality in terms of her lower urinary tract, I think it's reasonable to proceed with a sling procedure without pursuing urodynamics. Now, if she's had a prior procedure, or if there's concern about her bladder capacity, let's say she has fluid incontinence and you're worried that closing that outlet or tightening that outlet might worsen her bladder compliance, then that might be an indication for pursuing urodynamics.
So I know that the guidelines say so, every guideline says so. I just wanted to know the real lifetime practice at your institute.
Yeah, I mean, I'll say for the most part, patients who have uncomplicated stress incontinence, we don't pursue urodynamics. Unless, again, there's something about the patient that's not quite right, or, you know, they have a very strong urgency component that is just not clear, then that would be the indication for it.
Okay, just let me ask you the last question before you leave, if you have some kind of work. But if you're going to do Botox injection, botulinum toxin injection for the patient with refractory overactive bladder, you're giving her medical treatment, it's tried with the bladder neck techniques, whatever. And then you tell the patient, we will go for Botox injection. Do you still need to do urodynamics, or you have ever proceeded to Botox without urodynamics?
Yes, I've offered Botox to patients without urodynamics. I will say the caveats in terms of patients I consider especially are really young females, just because, you know, they may have some sort of element of dysfunctional voiding and or an occult neurologic problem. So those would be patients that I definitely will want to investigate with urodynamics first. If a patient has any kind of upper urinary tract issues, so let's say they have hydronephrosis or, you know, poor kidney function along with their overactive bladder, those may be other indications to pursue urodynamics. But yes, I've offered Botox patients who failed first-line therapy without giving them urodynamics.
And if this patient has failed the Botox injection afterwards, wouldn't this put you inside a kind of why did you inject me and there's no detrusor overactivities?
Yeah, good point. So if they fill Botox, then they should definitely get urodynamics. The only other subpopulation that might be questionable are, I don't want to call them elderly women, but elderly women with impaired detrusor, detrusor function.
DHIC syndrome. Yeah.
Exactly, DHIC. So detrusor hyperreflexia and impaired contractility. Those women are the women that tend to be at risk with Botox injection. I don't necessarily know that urodynamics might change your management. It might just help you with counseling the patient better upfront in terms of what to expect after Botox.
Thank you so much.
For my question, it's in the practice, in the real life, when we have urinary incontinence, for example, associated with genital prolapse and genital prolapse, for example, sister cell with pure incontinence, urinary incontinence. And this laboratory of urodynamics, it's not always easy to access to this procedure. In this case, I don't know if it's obligatory to have this urodynamic study before doing the surgery, or we can do it our surgery without. It's like the patient that we have done today. We don't have a urodynamic. I think we have yes, but in the real life, in the other city, the urodynamic procedure, it's not easy to have it. Yeah.
So actually, this is the dilemma which we all live in. I don't know. It's in every kind of conference we go. This is a kind of debate. It's always every year. But let's talk about the practice with the guidelines. What they say. We have two scenarios. The first scenario is the patient who is coming with pelvic organ prolapse and she does not have any stress urinary incontinence. Okay, and we have data that this patient may develop stress incontinence afterwards, if they did not have even occult stress or if they had occult stress incontinence. This is one entity. The other entity is the patient who comes to you with a pelvic organ prolapse and stress or urgency urinary incontinence. To make it easier for the second subset of the patient, I mean those who have stress incontinence and pelvic organ prolapse, both, if you look for the guidelines, it will tell you have to put a tape for the patient or have to treat the stress urinary incontinence. But actually, it does not really tell you what kind of treatment you will offer for the patient for the pelvic organ prolapse. And then here comes the debate from, because we know now there's a rise in the use of the abdominal sacrocolpopexy over the use of meshes because of the condemned use of them and the incidence of erosions, or any vaginal approach. Because if you do the kind of repair with the abdominal sacrocolpopexy, according to the Lancy, this is level 1. So you usually restore the site of the uterus up, high up. And theoretically, you do kind of correction of the urethrovesical angle. And in these patients, we have seen in some studies, I even did one of these studies also, and we found that this patient, when you do only abdominal sacrocolpopexy, the stress incontinence disappears. So here, if you go for the guidelines, it will tell you do kind of surgery for the stress incontinence. But if you go for the real life, we have two schools. I'm one of the proponent of the school to do the abdominal sacrocolpopexy, and then you tell the patient to wait from 3 to 6 months. If the urinary incontinence is there, then we can just go and put a tape, and this is a simple procedure. But we have seen a lot of patients which really have been cured by just one operation, because we know the tape has a kind of erosion and it has its complications. So this is for the subset of this patient, which is coming with incontinence plus prolapse. For the patient, of course, with prolapse and without urinary incontinence, the guidelines tell you not to do, and you have to weigh the risks to whether to put the tape or not. And if we say in some patients who also have urinary incontinence and you do not put a tape, what about the patient when it comes to you and she does not have urinary incontinence? So this is how I manage my patient. This is according to the guidelines and even also to the real life practice. But we would also like to hear from you because the question is also for you.
Mm-hmm. So in our practice, I would say that, it depends on the degree of prolapse. So let's say a woman comes in with prolapse and stress urinary incontinence at baseline. Now, if her prolapse is not to the level of the hymen, you could argue that you could just treat her stress incontinence, but counsel her preoperatively that, if her prolapse progresses, that could be a point of obstruction for her later on. And so she could have more urgency symptoms. Now, if let's say she has prolapse beyond the hymen and she has stress incontinence preoperatively, I usually counsel them, dependent on the patient characteristics, about worse than stress incontinence after pelvic organ prolapse surgery, and I offer them a sling procedure at the same time. Now, if it's an elderly woman who I'm worried about impaired detrusor contractility, you could argue that you could give her a less obstructant sling. So some people believe that a TOT sling might be less obstructive than a retropubic sling. Now, for the woman who has no stress incontinence prior to her surgery, how do I counsel her? I counsel her that that she has a risk of in the 20-30% range of developing stress incontinence after her surgery. Typically, in our clinic, we will do something called cystometrics, whereby we fill the bladder up with fluid, we reduce the prolapse and have them cough and see if they leak urine. If they do leak urine, then that's usually a strong indication that a sling procedure might be of benefit. But again, they're offered a staged approach regardless of whether they leak or not. So that's usually how I proceed. Now, you mentioned something about kind of stage and thins with an abdominal sacral colpopexy and then waiting 3 to 6 months before you do your stress incontinence procedure. I think that's an interesting discussion point because some people do believe that prolapse surgery might help with any kind of mild stress incontinence. I haven't really seen very much literature that is fully curative.
Thank you. Excuse me. For this kind, when we have incontinence urinary, especially with the overactivity of bladder, here I think if we have a genital collapse and we make a mesh for sacrospinal fixation, here we have the risk to aggrave the symptom. And I think in this situation, if we don't do urodynamic study, it can be a problem for the surgeon after, because if we have a real overactivity of bladder, when we make the mesh, it can increase the risk of overactivity of the bladder. What do you think about this situation? Because we have the urodynamic study, we have a prognostic of the patient. Because I have some situation of this kind of patient that I have overactivity of the bladder with the prolapse, and the patient, the problem of the patient is overactivity of the bladder more than genital prolapse. And for this patient, when they don't do the urodynamic study, and we make a mesh, the life of the patient, it's transformed very cauchemar. I don't cauchemar. That in this situation, it's very important. I think that we have to do this urodynamic study. I don't know what do you think?
has a patient tried like a pessary, for instance? Because I mean, I think in that situation where there is some reticence about surgery and implanting a mesh, you could consider a trial of a pessary and treating her urge symptoms and seeing if that kind of optimizes her urinary symptoms before she gets prolapse surgery.
Treatment with
Yes.
yeah.
She's telling you
You can use before.
Pessary is a kind of
Yeah.
It's like kind of a prolapse surgery.
Yeah,
And the
yeah.
patient has kind of improved now.
Yeah, in Morocco we have a problem with the pessary to have it in the pharmacy. I don't know. Sim Sharqi, le pessary, il est disponible.
Yes, we have.
We have a problem of disponibility of the pessary. Yeah.
So actually, I will tell you also my experience in this one. I totally agree to do urodynamics, but the problem is after you do the urodynamics, if you found the true overactivities for this patient, we have to understand well whether this patient has a prolapse that necessitates treatment, that it's stage 3 or 4 or more than 2. I mean that she wants to go and do repair of the prolapse, or she's only coming symptomatic of overactive bladder and have stage 1 to 2 prolapse, stage 1 to 2 prolapse, and you have most symptoms of overactivities, then you do not treat the prolapse. So for this patient, you have just to go for the cascade of the treatment of overactivities. I totally agree. But what if the patient is a candidate for the treatment of a pelvic organ prolapse, has a higher stage, for example, and she has overactivities? Actually, we have some papers which say that these patients will benefit from the prolapse surgery when they do in terms of the true overactivities. And we also have some more sophisticated papers coming from Germany. You know, the Caressa or Varessa, this is a kind of surgery. They say that this is the only surgical treatment for overactive bladder. They put some kind of meshes, passing it through the uterosacral ligaments, just like you do the sacrocolpopexy, but they pass it through the uterosacral ligament based on the theory proposed by Petros and Palma. Papa Petros from Australia, and accordingly they say they cure the true overactivities. But if you go for any conference, this is not quite accepted and it's not even mentioned in the guidelines. So what do you think about this one too?
I'm not familiar with that technology. Can you describe it more and kind of what the basis of their the mechanism is with the uterosacral suspension?
It's a kind of assumption, you know, that it's the theory they have been proposed, but actually did not gain acceptance. But they have published many papers in German talking about this. But we know that if you treat prolapse by any kind of surgery, whatever, you will have some kind of improvement of the patient's overactivities. Maybe it's a kind of irritation by the prolapsed bladder. I don't know. So this is well my answer for this question.
Yeah, no, I think that's a great answer. I mean, there are several papers to your point about that specific subject. So there's one paper from Finland that was called FinPop. They did a registry of different prolapse procedures, and they looked at women's overactive bladder symptoms, and they looked by stage of prolapse, and basically they concluded in that study that irrespective of stage of prolapse, when you do a prolapse procedure, that women have improvement in their overactive bladder symptoms based on like the UDI-6 symptom score. Now, there are a lot of issues with those specific papers and kind of how they calibrated things, but they did make a point that, you know, prolapse surgery might have benefits in terms of overactive bladder symptoms. The mechanism is not entirely clear. Some people believe that, you know, overdistension of the bladder, you know, with overactive bladder might from prolapse might be one of the reasons why people have more detrusor overactivity in that population. Also, if a woman has advanced prolapse, we know that, you know, because of her cystocele or intervaginal prolapse, there might be some sort of obstructive component that might contribute to overactive bladder symptoms. So, I mean, how would I treat this patient if she were to come into my office? If she has a bothersome vaginal bulge, as well as, you know, urgency symptoms, but is concerned about, you know, what prolapse surgery might mean with a mesh, I would offer her a way to reduce that bulge, so a pessary, and then see if her overactive bladder symptoms are improved. If they're not improved, then I'll go down the OAB pathway and treat her urinary symptoms. If her vaginal bulge is not bothersome to her, or is, like you said, not at the level of the hymen, then you would work on her overactive bladder symptoms. Now, there are also studies in the literature that show that, if she has mixed incontinence there's a component of stress, that treating her outlet might actually also improve her urgency symptoms. So I would say that, if she does not have advanced prolapse and she has mixed incontinence, then you can also consider some sort of outlet procedure and see that also improves her urgency.
No comment for you because your case or your question is very interesting and practice. But you don't know aerodynamics is normally complex stress incontinence with prolapse. Normally, we can study the case in multi-purpose consultation before to indicate intervention, because today aerodynamic study is medical legal in France, in Morocco not yet, but it's comes in future. Second case, normally prolapse or pelvic floor disease associated with urgency or over bladder. Normally, many cases, when we treat the prolapse, we can improve urgency or over bladder, but you must warn the patient before. If not improve after, she can continue the treatment with the anticholinergic. What do you think about that, Oritimi?
In terms of treating with anticholinergics first, is that what you're saying?
Yes.
Yeah, I mean, I think that that's a reasonable start. Usually, again, whenever I see a patient, the important thing is to know what their biggest bother is. So if the bother is primarily from, her urinary symptoms over her vaginal bulge, then that should be prioritized. As long as there is a concern that the bulge is not, worsening or exacerbating her urinary symptoms. Typically, we avoid anticholinergics here in the U.S. Just because of the association with dementia and a lot of the side effects. So we tend to offer mirabegron first, but I understand that it could be also limited in terms of its availability elsewhere.
Excusez-moi, je parle en français. Alors, pour le problème de l'incontinence, je crois que c'est un problème de diagnostic clinique. Donc, le problème quand on n'a pas d'incontinence qui est objectivée. Donc là, l'exploration urodynamique peut nous aider à mieux comprendre la symptomatologie. D'autre part, actuellement, on conseille de ne pas associer la cure de prolapsus avec l'incontinence et que la femme soit informée si jamais l'incontinence persiste. Donc, on pourra la reprendre ultérieurement et que peut-être tout le problème sera réglé parce que la présence du prolapsus avec comme pathologie sous-jacente, périnée relâché, insuffisance sphinctérienne, tout ça, c'est à identifier. D'autre part, il y a un problème essentiel, c'est la deuxième phase. On n'a parlé que de la première phase. La phase mictionnelle. On sait très bien que vous l'avez dit aussi, la femme peut uriner en se relâchant. Donc, elle peut avoir une débimétrie correcte, mais il peut y avoir une hypocontractilité vésicale sous-jacente chez des femmes qui ont des problèmes, enfin qui ont accouché avec de gros bébés. Ensuite, la constipation qui est un facteur de risque très important. Ensuite, les problèmes de rachis qui peuvent exister chez des femmes d'un certain âge. Donc, tout ça peut avoir comme conséquence une hypocontractilité vésicale. Et donc, même si une débimétrie est correcte, il est préférable d'avoir une exploration comme élément de pronostic. Ce n'est pas le diagnostic, mais de pronostic et d'éléments en plus pour bien choisir le geste et la technique qu'on peut proposer à cette femme-là pour ne pas créer une vessie rétentionniste en post-opératoire. Alors, une question pour vous. Vous ne parlez pas de la prophylométrie.
This question was about, the first one was like a comment, and it was talking about that the patients, we should also put in other associated comorbidities, like patients who have hypocontractile, but especially the females with the constipation, or they have been having multiple deliveries, so they will develop these hypocontractile bladders, and we cannot really diagnose them with this during our clinical scenarios for these patients. So we have to put this into consideration. And usually, yes, we say this. And also one important thing which the doctor said was about, we do not relate between the cure of incontinence and the presence of the true urovar activities, because there's kind of expectations for the patient. We should put this into consideration. The question was about the Uroflumetry, UPPs, urethral pressure profile. And I said, I know it, but we don't do it because there have been many fallacies, there are many artifacts while using it. And actually, that's why we don't use it anymore, even in Egypt, or I know also in the States, they don't use it. But I also would like to hear from you. For myself, I only did it for patients in an investigational, in a paperwork. I did it because we had some kind of paper and want to publish, and we wanted to measure the UPP. But other than this, in the practical life, I don't do it at all. What about you?
I will say that I have no experience with UPPs whatsoever. And a fair number of urologists don't use it. So my mentor, Dr. Victor Nitti, doesn't use it at all. Now, in some urogynecologic practices, they still use the urethral pressure profile, but by and large, most people don't.
The same school, she does not use the UPP like we don't use. I don't know, do you use UPP? No. Even here in Tunisia.
Le pressure, la pression de la fuite urinaire quand tu fais la prophylométrie, est-ce que tu fais la... Non.
I only know the some
Only in the box.
Some
Okay. En fait, on en parle que dans les livres, hein, et les diplômes dans les certificats.
Dans la pratique, c'est pas évident.
C'est pas évident, mais c'est vrai.
Bon, on parle de l'exploration urodynamique, vous avez parlé de l'artefact au niveau de la prophylométrie et tout, c'est tout à fait. Mais un examen urodynamique, en général, il faut bien préparer la femme. Parce que ça prend du temps, il faut la préparer.
Oui, préparer la femme. Qu'est-ce que ça veut dire pour toi, préparer la femme?
Préparer la femme, l'informer tout d'abord de ce qu'on va lui faire. La relaxation, la mettre dans une position.
Micro. Non, s'il ne parle pas dans le micro, il ne sera pas, les autres ne vont pas l'entendre.
Alors, pour revenir, pour une exploration urodynamique, ce n'est pas un examen simple. Déjà, les femmes arrivent sans savoir de quoi il s'agit. Ensuite, généralement, à un certain âge, des femmes âgées, vraiment la pudeur prend beaucoup de place et donc on a du mal à les mettre en position pour faire le travail. D'autre part, quand on parle de sonde, c'est toujours la panique. Donc, on les prépare on va faire ça et ça et ça. Ensuite, on prend le temps de les mettre, de les relâcher pour essayer de faire un examen aérodynamique. Ensuite, moi, quand je fais un examen aérodynamique, il faut quand même faire l'examen neurologique et les testings musculaires et tout. Donc, tout ça, il faut que ce soit une femme bien relâchée. Et quand on la prépare, on arrive à faire quand même un examen où il y a beaucoup moins d'artefacts. Par contre, si on met une malade sans la préparer, à coup sûr, tout l'examen, même la cystométrie, peut être fausse et on peut avoir des hypersensibilités, des hyperactivités, tout ce que vous voulez, sans que ça soit vraiment la réalité.
Lorsque vous faites le bilan urodynamique, donc par jour, vous faites combien?
Moi, je fais 2-3 le maximum.
2-3 maximum, c'est ça. Et ça prend toute une demi-journée, minimum demi-journée. C'est-à-dire une heure par... enfin, 45, 1 heure.
Le dossier, parce que vraiment, on arrive déjà, on ne connaît pas. Il faut faire recueillir les éléments cliniques et tout. Ensuite, préparer le malade en lui expliquant. Et faire l'examen, il faut que ça aussi, on commence par une vessie pleine. Donc, il faut que la femme arrive déjà avec une vessie pleine pour faire un examen, pour voir, constater les fluides, faire les manœuvres, tout ça, ça demande quand même. Et une fois la maladie préparée, donc on peut faire à ce moment-là, l'examen peut prendre 3 heures à peu près, maximum. Et ça dépend aussi de la capacité visicale. Si vous avez une grande capacité visicale, donc vous mettez encore plus de temps. Parce qu'on remplit la vessie avec un débit faible. C'est autour, ça dépend de entre 30 et 50 litres minutes.
25.
Donc, ça prend, si vous avez une capacité de 700 millilitres, donc vous avez du temps à faire.
Alors, cet examen, vous le faites vous-même ou vous laissez l'infirmière qui le fasse et puis vous l'interprétez?
Chez nous, là.
Je le fais moi-même,
Voilà.
de A jusqu'à Z. Moi, j'ai une assistante qui m'aide beaucoup, mais ça reste...
Ah non, c'est un examen quand même que le médecin doit faire.
Et puis, c'est quand même une intimité, c'est ça le problème. Nos femmes, c'est des femmes qui ont... c'est tabou, ça reste tabou quel que soit l'âge. Et donc, pour elles, pour la terminer...
Tu prends le micro, s'il te plaît, parce que sinon, les autres, ils ne vont pas nous entendre.
Alors, en général, dans le milieu tunisien, je parle, quand la femme a terminé d'accoucher, pour elle, le problème gynécologique, c'est terminé. Donc, quand elle arrive avec ce problème-là, elle a dit « Mais mon Dieu, moi, j'ai terminé, je me mets dans cette position, tout ça. » Donc, déjà, c'est du temps à préparer la malade pour la mettre en confiance, pour lui expliquer que de toutes les façons, c'est nécessaire et tout ça. Donc, tout ça, c'est du temps, mais qui est... Ce n'est pas du temps perdu, mais c'est au contraire gagné pour avoir un examen représentatif. Donc,
oui, non, mais
et je le fais toute seule, bien sûr.
Évidemment.
Et des fois, on est obligé même de refaire un deuxième remplissage. Quand on n'est pas convaincu que
oui.
le premier remplissage, la femme n'était pas bien relâchée et tout ça, ou alors on a du doute, on refait, parce que des fois, on découvre des vessies neurologiques réflexes à de petites capacités. Donc là, un seul remplissage ne permet pas d'étiqueter vraiment l'anomalie.
Alors, oui, moi je complète ce qu'il a dit, et ça c'est très intéressant, que les gens qui ne font pas le bilan aérodynamique, ils n'ont pas cette intuition, ils n'ont pas cette capacité de comprendre qu'un examen aérodynamique, c'est relationnel en premier avec le patient. Parce qu'avant de faire le bilan, il faut préparer le patient ou la patiente pour le mettre à l'aise, parce que il se met dans une position et tu touches une partie génitale quand même assez importante pendant un certain temps et tu vas le remplir. Le plus souvent, la question qui revient, qu'est-ce que vous allez faire? Quand on lui dit on va remplir la vessie, étudier le comportement de la vessie au cours de remplissage, il dit, oh non, ça lui rappelle. Et vous allez, il vous dit, et puis il vous dit, vous allez me faire ça ici sans anesthésie? Ça, c'est très important. Ça revient toujours. Deuxième chose, ce qu'il a dit Zeynep, quand le patient tu le laisses faire le bilan avec une infirmière, pour lui, c'est un examen que l'infirmière ne doit pas faire. C'est un examen, surtout quand il est adressé par un confrère et qui lui dit, on va vous envoyer chez quelqu'un pour faire un bilan. Et il ne se trouve pas avec ce quelqu'un, il va se trouver avec une infirmière, avec une nurse qui est en train de lui faire le bilan. Et puis, je m'excuse, les infirmières ou les techniciens, ils n'ont pas le feeling comme nous. Quand tu es en train de remplir et tu assistes à l'examen, ce n'est pas comme un examen. Le bilan aérodynamique, c'est un examen qui bouge. Il est en mouvement. Tu sais ce qu'on appelle le bilan aérodynamique en arabe? الاختيارات التحولية للبول. Et c'est très important. Et ça explique tout ça. Vraiment, en arabe, la traduction, elle est magnifique. Vraiment, il te résume la situation. Et comme le design aussi, il y a des fois où tu es obligé de refaire la manométrie parce que la sonde elle est tombée, le technicien n'a pas fait attention, soit la sonde elle est trop foncée et il hérite la vessie, soit la sonde elle est en dehors et tu n'as pas vraiment complètement la pression vésicale réelle. Donc, il y a et puis, autre chose qui est très importante, le réglage de l'appareil au début, elle est très, très, très important. Ça te prend du temps et c'est ça, c'est parce que si tu commences avec un faux zéro, ben le bilan, elle est zéro. Tu es obligé de vider la vessie et revenir par la suite, refaire un autre examen. Alors, ça, c'est pour un bilan aérodynamique en général. Mais quand il s'agit d'un neurologique, c'est encore pire. Parce qu'un neurologique, tu es en train de le remplir. Et puis, à un moment donné, tu vois la pression nitrosonienne qui passe comme ça. Et à ce moment-là, tu dois capter ce mouvement, tu dois le vivre. Et ça aussi, c'est un élément important. L'examen aérodynamique doit rester un examen, à mon avis, médical. D'accord.
Okay. So all this was just to make it clear. We'll just give you like a resume for what they have been talking about. The first thing we were talking about is that we need to prepare the patient very, let's say, accurately on giving them their thorough history, giving them what we will do, the info, how they will do the study, because usually we can tell the patient you have to go and do urodynamics, and then the patient comes to you, thinks that this urodynamics is kind of an ultrasound or something like this, but actually we insert some kind of catheters. You have to tell the patient what she will feel and what she will, this is a very important thing. So this was the main thing that we were talking about, the preparation of the patient for this kind of, let's say, embarrassing study or some kind of unusual study. The next thing we were talking about, who is performing the urodynamics. Is it the doctor himself or it is the nurse? And the question has been asked to us both, me here in Egypt and at your place, who is doing the urodynamics? I'd say in my practice, I do the urodynamics by myself, me as a doctor, and I should attend every urodynamics. I don't believe to take a kind of a result which is done by the nurse and just to read the curve, because this is not right. Because you can see, I'll give you a very, very obvious example. We have females which come complain of overactive bladder, and you want to do urodynamics to see the detrusor overactivity. But when you do the study, you don't see any kind of detrusor overactivity. This is quite common. So if you are there, when I see this, I will tell my patient, are you just trying to inhibit or preventing any kind of leak? And says, yes, I'm doing so. So I tell her, no, just leave yourself. I want to see the overactivities. So she leaves herself, and then you can see the overactivities. If I'm not attending from the first time and I didn't see this, I will only see the curve, and I will tell my patient when she comes to my clinic, you are free, you are normal, you don't have anything. So that's for like a kind of an example that why you should attend, because you determine when to increase the rate, when to decrease the rate and so on. So I believe urodynamics should be done by a urodynamicist, not by a nurse. She's assisting me, but she's not doing, because interpretation of the urodynamics is very, 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 very important. I don't know what's about your practice.
Well, I will say that, you know, it really depends on the institution. So at UCLA here, I am at 3 different hospitals. At our main hospital, we have a trained nurse who does urodynamics every single day. So she's pretty experienced, and a lot of the doctors have worked with her to understand how she does it, to make sure that it's technically a sound study. Now, I do agree with you that, you know, because urodynamics is, you know, is usually done to answer a specific question, it's important that either the question is communicated to the technician that's running the study, or that the physician should be in the room to be able to interpret the key aspects of the study, and to troubleshoot it and adjust accordingly. So for patients that, you know, have specific indications that are either not clear, or I want to see like their avoidant phase, for instance, or I need to see that they urinate, or let's say I'm looking for something anatomically on the fluoroscopy, for instance, I will be in the room along with the nurse to make sure that it's done accordingly. Now, in a lot of practices, a lot of people have nurses that will do the study. So there will be some variation in how things are done.
Oui, mais les nurses diplômées, c'est important aussi. C'est très important. Ah, oui. Yes. Mm.
If you got too much money, you will do the study by yourself.
And I mean, and some of it might also be driven.
Time is money.
Yeah, some of it is driven by compensation too. So, yeah.
What device or machine do you have
We use a library.
in your institution?
We use a library machine.
Lower? No.
Library. Yeah.
Yes. It works with TDoc. Yes. Yes. Question. No.
We have the machine test, but we have to.
Micro.
We have the machine library. I think it's 2010, and I think we have to make like a mise à jour. Yeah. Update of this. Yes, we have to make the update, and to buy the sound.
And TDoc. It's a big problem, TDoc.
You don't have the sound?
Non, TDoc.
Yeah.
Ce sont des sondes qui gonflent à l'air.
Yeah.
And no, I prefer with the
library with liquid.
No, with liquid,
yeah,
or electronic sound. It's please, yeah, but very expensive.
Just to add, want to add one comment, because we know that library already bought MMS, which was the second most competitive for the library. So library now owns library. So if you see library, it's library by itself, and if you see MMS, you can see that MMS and under this library sign. So everything is owned by the same company, and they have just like library removed some models they have, and they kept these other models, the equivalent to them in the MMS part.
I don't like library because yes, no, yes. Non, il n'est plus américain, il n'est plus canadien, il est américain, acheté, c'est vendu. Mais in Congress AUA, I discover another label protease, you know, with the video aerodynamics.
No, I'm not familiar with them, but is this a newer company?
Yes. With the video aerodynamic and with ultrasonic in the same machine.
Oh, okay, wow.
It's late for you, no?
Yes, I probably
Okay,
have to
okay.
run soon.
Thank you. And tomorrow we will be with us to present your communication, est or not, with the colpocclusis. Can you?
Yes,
In
I'll
the
be
same
happy to.
time?
Yes, so
Tomorrow?
it'll be 11 a.m. So the same time as
Same
one.
time tomorrow, yes.
Okay,
Thank you. Thank you.
thank you.
Ouais. Oui, maintenant, chez eux, c'est 11 heures. 11 heures du matin. Ça va. Alors, est-ce qu'il y a des... Bah, écoute, mon ami, il y a beaucoup de questions qui vraiment qu'on a notées, mais je pense qu'on va arrêter parce qu'on laissera pour demain. Oui, pour demain, parce qu'aujourd'hui, je vous ai fait travailler. Oui, alors, bah, écoute, on va clôturer donc cette première journée de la deuxième journée nationale de l'incontinence urinaire de la femme. Je remercie tous les orateurs, je remercie tous les présents et je remercie tous les gens qui nous regardent, qui nous ont suivis à travers Zoom. Je vous donne un rendez-vous demain matin. Demain matin, c'est un programme qui est très chargé. J'espère qu'on va commencer à 8h30. C'était prévu à 9h, mais parce qu'il y a beaucoup d'orateurs qui m'ont imposé un horaire. Et donc, demain, ce soir, je vais travailler à chambouler tout le programme et il se peut qu'il y ait plus de liaison entre les communications parce que je suis obligé. Et donc, Dr Masmoudi et Wali, comme vous êtes avec nous, donc on va essayer chaque fois que possible vous faire passer parce que et voilà. Voilà, ben, je remercie tout le monde et puis bonne nuit et bonne soirée.